Thanks, Om, for the lovely introduction. And since I always wanted to roam around on the stage like this, but stopped myself. So thanks for inspiring me to fulfill that. So he's given us a great introduction about Tirzepatide. We've understood the molecule and understood that obesity is the way forward in the field of metabolic medicine. And he talked about looking towards the future. Well, I correct what he said in saying that we are living the future. We are practicing the future. And one very important question is I'm going to be answering today is going to be for the physicians, and not just the physicians, because of the amazingly large media and the social media noise about these drugs. The patients ask this question, Semaglutide or Tirzepatide. So he talked about two categories of patients in his slide set, obese, non-diabetics and diabetics. So we're going to break it off in a prototype case for each one of these and see how these two drugs compare. Interestingly, while flying from Delhi, there were these two people sitting next to me. I was going through the slides, and one of them, hypertensive, dyslipidemic, obese, he saw the title and asked me, sir, isme se kaun sa acha hai? That's the level of awareness happening. So what he said and what we are experiencing, and patients walking into the OPD saying, I want to lose weight. Tell me when did this happen? This is the future we are practicing. So, redefining the weight loss goals. We've always set the goal. We were not able to achieve it. We had all these drugs available, but for whatever reasons, they went out of the market. So, incretin-based therapies are now here to stay, and let's see what we can achieve with them and compare Tirzepatide and Semaglutide. This is my disclosure. So the first prototype would be of an obese, non-diabetic young lady who has the metabolic impact of excess adiposity in the form of dyslipidemia or MASLD. The second aspect of adiposity in this patient would be her physical inability, or what she calls as a disability of doing the day-to-day activities, and the doctor says you have early osteoarthritis. The third part, which is usually underreported, usually not assessed by a clinician and never addressed, is the mental health impact of excess weight. She's gone through multiple attempts, failed attempts, weight regain happening over these years, which has made her feel very bad about herself, her body image, her self-esteem, her mood, all have been affected. So this would be a classical picture of having the metabolic, the mechanical and the mental impact of adiposity in this patient. So it becomes kind of an emergency. He talked about preventing so many metabolic disorders. So very simply, over 225 diseases, disorders that the patients are predisposed to, and possibly the only intervention known in medical science which promises to provide these many number of benefits is weight loss, and that's why we are practicing the future. So on a discussion, because of all of these, diet, exercise, I'll cut the chase here. So there was a debate here that which drug? We said, oh, you need a weight loss drug. Patient raises that question. So let's see what science we have about these weight loss drugs. And we've already stated greater amount of percentage of weight loss will translate into better health benefits. The benchmarking 15%, remission of diabetes, benefits on heart failure, 20% we're talking about mortality and morbidity benefits. That's the quantum of benefit that weight loss provides. It's a linear relationship, greater weight loss, greater benefits happening. So this is the pretext of deciding to give a weight loss medication to this patient. Om talked about the trial program for Tirzepatide and the large number of people enrolled in it. Very simply, the first raised this question, does this drug work? Yes, it does. He talked about the numbers. The second talked about, does this drug work or help in weight loss in diabetics? Tick mark, yes it does, very effective. The third questioned that what about a front-loaded approach where we give the patient a lifestyle change and then start the medication? Well, logically, as a clinician, it will give you the better results. The fourth of these trials, what happens if you stop the drug? Weight comes back. So these drugs are intended for a long-term use. I don't use the word lifelong in clinical practice, but essentially it means the same. But the final one is the question the patient asked me, doctor, would it be Semaglutide or Tirzepatide? So I would be taking up the SURMOUNT-5 trial here. So equal number of patients were, the doses were increased to either 15 milligrams of Tirzepatide or Semaglutide 2.4 milligrams. Interestingly, about in excess of 80% of these patients, which were equally divided 1:1, achieved the maximum dose, which is 15 milligrams and 2.4, which is good for statistical analysis. So what came out of this, as he showed in the previous slide set, there was a 6% difference. And that 6% difference actually translates into a big difference in organ protection. I'm making it very simple. We know all the organs, the heart, the liver, and he very beautifully talked about how the fat melts. It's very, very true. So no questions about the quantum of weight loss is 6% more. And in clinical practice, now let's come back to our clinic. What are our patients seeing? You see these numbers, the red line is actually the 15 milligram dose. Our Indian patients lose much greater weight, tolerate the drug better, and are showing very high percentage of weight loss even at lesser doses. So no off-label discussions here, but we respond better. And the average dose, if you ask me, to reach a certain health benefit would possibly be lower than 15 milligrams, with maybe 20% people requiring the highest doses. That's my clinical experience with Tirzepatide. So we talked about quantum of weight loss. Just focus on the last part of it. More than 25% weight loss. We're talking about bariatric range weight loss. About 40% of these patients are achieving that 25% weight loss. And there are ongoing trials talking about, which are evaluating medications for weight loss and seeing what happens to longevity, what happens to morbidity and mortality. Well, this is the future. We are practicing it. I'm repeating it again. 25% weight loss we could never have dreamed about. Well, our patients are experiencing that. Quantum of weight loss, again, a big tick mark. This slide actually makes me smile when I present it. From a clinician's perspective, waist circumference in the Asian Indian population seems to be the biggest benefit we can give to our patients. Whichever conference, whichever textbook you talk about cardiovascular diseases, NAFLD, all these things, you talk about abdominal obesity, visceral adiposity, and waist circumference is the easiest way to assess that. An 8-inch loss of the waist circumference would translate into a much greater health benefit. We need to actually prove that. Now, this is from a clinician's perspective, the health benefits of reduction in the waist circumference. However, from the patient's point of view, they are happily unhappy. Well, why are they happy? That yes, they've lost so much of weight, but they're unhappy about the fact that their entire wardrobe needs to be changed. Just imagine what would happen if I lose 8 inches on my belt. And that's a part of the mental health impact of losing weight. Their self-esteem goes, their professional performance becomes so better, their knee pain is disappearing, and after a year, you do a MRI, like Om said, you'll find the liver spick and span clear. It's like remitting a disease. And that's the beauty of these, that's the power of these molecules. Adverse effects, he's talked lots about. Comparing them head to head, there doesn't seem to be much difference as per this slide. However, in clinical practice, we see our patients tolerating the drugs better, and actually, I totally reflect what Om said, that they're demanding the doses to be increased because they want more, and they're tolerating the drugs well. And he commented very well about the constipation part of it and the water intake being really a good clinical tool in getting them through with that. Adverse side effects happen usually initially with dose escalations. You may halt at the certain dose. You don't need to continue or increase the dose every month. It's the balance in between the clinical benefit and the side effect which gives you the skill of getting them to the target as soon as possible with the most comfortable, convenient way. The second prototype, as you see, the patient is like this. A classical presentation, relatively long duration of diabetes, nearing a decade of diabetes, uncontrolled diabetes, not uncommon for all of us to see in our OPD in the first time. However, why is he like this right now? Unfortunate events around him, he's heard it, he's seen it in the family, in the media, in the social media. Now he's really concerned. Now I really need to lose weight. Because he saw on the social media that there are these drugs which protect the heart, the liver, the kidney, make you lose weight. I've got excellent profiles. So he comes to us and starts a discussion about the weight loss medication. So here again, we will raise this question from one of the slides that Om had presented earlier, the SURPASS-2 trial, where there was a head-to-head comparison of Semaglutide and Tirzepatide. Now, Semaglutide here was a 1 milligram dose, and Tirzepatide was 5, 10, and 15 milligram doses. Like our patient, the average A1C here was 8%, but what is very interesting to me as a clinician, that 8.6 years of diabetes, we would never think about remission of diabetes with such a duration of diabetes. And I request an extra few minutes from the chairpersons. So what happened here, you see the stark difference. 1 milligram semaglutide, the least dose of Tirzepatide, which was 5 milligram, clocked a better A1C reduction. And the trials for Semaglutide 2.4, though there was a mixed population of diabetics and non-diabetics, clocked a 1.6% reduction, not shown here. And when you go up to the 15 milligram, we are clocking a 2.5 milligram percent reduction in the A1C. And he rightly said, other than insulin, this is the most powerful medication, whether you talk about weight loss or you talk about A1C reduction. So we are reflecting each other's thoughts as a clinician of deciding the right tools. Again, the left part of this is the most exciting to me. 8 plus years of diabetes, where you would never think about remission. With these drugs, 1 out of 2 are achieving a A1C less than 5.7%. Now, this is the randomized controlled trial data. Now, our patients on these drugs are coming back in the subsequent months. They've been on doses in excess of 5 milligrams, 7.5. They're coming with these numbers of less than 5.7, and we had to discontinue most of their medications. So pharmacological remission of diabetes is a reality, is happening. And that's what exactly this slide shows. Weight reduction again in diabetics is lesser, but even the least dose of Tirzepatide helps in better weight loss. So you take a composite of A1C reduction, weight loss, and safety in the form of hypoglycemia. The 15 milligram dose provides an excellent glycemic control, excellent weight loss, and an equitable chance of hypoglycemia or a reduced hypoglycemia, the safety aspect, as compared to just 22% of patients of 1 milligram semaglutide achieving this composite outcome. Adverse, again, same, won't repeat in this, so I end here. in living the future of metabolic medicine, addressing adiposity as the main target of our treatments, with Tirzepatide providing us one of the strongest tools for a safe, effective, durable weight loss and associated excellent HbA1c reduction with the safety aspect of virtually no chance of hypoglycemia, as we heard, because it goes and attaches to both the receptors. And I thank all of you for your kind listening. Thank you very much.